Sorry. Today's discussion on multiplex PCR, the usage of multiplex PCR in identification of MDR organisms, and for that we have our esteemed speaker, Dr. Prashant Nasa. Dr. Prashant Nasa is head of the Department of Critical Care at NMC Hospital Healthcare Center at Dubai, and he has been in this field of critical care since 16 to 17 years. He's FNB Critical Care and former postgraduate from KM Hospital. He's a very good friend of mine. And welcome, Dr. Prashant, for this program. And we have the panelists with us, Dr. Vasant Nagvekar. Dr. Vasant Nagvekar is an infectious disease specialist and a physician at Mumbai, and he is affiliated to hospitals like Lilavati Global Hospital and H&D Lands Hospital. He has done pioneering work in the field of infectious disease. So I welcome Dr. Vasant Nagvekar, sir. Welcome, sir. And we have Dr. Abdul Ghafoor also. He is an infectious disease specialist at Apollo Hospital, Chennai. And he has also done a lot of research and paper publications in the field of infectious disease specialty. Welcome, Dr. Abdul Ghafoor, sir. And we have panelist, Dr. Pragyan Rotrai. He is the chief intensivist at Care Hospital, Bhubaneswar. And welcome, Dr. Pragyan.
Hi, thank you, Dr.
Yeah. And we have Dr. Divya Kukian. She is a consultant critical care specialty at Apollo Hospital in Navi Mumbai. Welcome, Dr. Divya.
Thank you, sir.
Yeah. So with this, I hand over the session for a brief introduction by Dr. Gunadhar, and then we will start the presentation with Dr. Prashant Nasa. Over to you, Dr. Gunadhar.
Yeah, thank you, Achilles. I think this is all the academic sessions mainly aimed focused at improving the critical care outcome for our DNBs, FNBs, or our IDCCM students and the fellowship students. So I welcome you all, and basically let's make this session interactive at the end of the topic. And with this, I just have one or two, three lines on the surviving sepsis and the sepsis campaigning. So basically, the aim of the sepsis is for the early diagnosis and the management. So the earlier we can diagnose, the burden of the sepsis will definitely goes down. And a lot of studies like the SAP studies, the ProData studies, everything has proven the same thing. So newer and newer technology has actually changed the paradigm of sepsis management. So the today's topic is basically based on the same thing. And with this, I welcome Dr. Prashant to have this present this talk. And at the end of the talk, we should take some questions from the delegates and we'll discuss with the panelists. Thank you. Over to you, Dr. Prashant.
Thank you, Dr. Akhilesh and Dr. Gunadhar and whole Mumbai team for giving me an opportunity to present on very important topic, something which is very close to me. And obviously we'll be taking questions at the end of this, the talk. So I'll start with my presentation, how it helps in clinical decision making, the tools like PCR and Multitop. So we know that antimicrobials are key to sepsis management. They have been recently recommended by almost all surviving sepsis guideline, the timing duration. And I think one of the key component of surviving sepsis campaign is to administer antibiotics early, preferably within 1 hour of recognition. And that is still being continued as one of the foremost recommendation. But, unfortunately, there is not even a single line in the surviving sepsis campaign, how to choose an antibiotic. So we talk about when to start antibiotic, definitely as early as possible. But unfortunately, there is no way they have recommended us how to choose an antibiotic. So still these 3 vague lines are there, which I could find in the campaign. A high risk of MRSA, one should consider an MRSA coverage. If a patient has a gram-negative suspected MDRO, one should consider the 2 antimicrobials. If there is a risk of fungal infection, one can consider an empiric antifungal. And similarly for an viral sepsis, one can consider an early antiviral for these patients. But we know that most of the time at the bedside, we have to still use these risk factors for identification of an MDRO, whether it's a VRE or it's a carbapenem-resistant Enterobacteriaceae or MDR Pseudomonas or Encinobacter. So we usually use these risk factors to identify which patient will have a risk factor for particular MDRO, and accordingly we choose an antibiotic for these patients. But if you look closely these risk factors, you will find that most of the risk factors have very much overlapping. There is substantial risk factors which will be available in all the organisms, whether it's age, whether it's previous use of antibiotic, especially in last 3 months, or it's an ICU admission. So preferably all patients in an ICU which have received an antibiotic in last 90 days will have likely to develop all these risk factors. And ultimately it will be back to square one, whether which type of antibiotic, whether I should cover up both gram-negative, gram-positive, whether I should cover MDRO or not. So that dilemma still stays with anyone who is practicing in intensive care, whether it's an infectious disease specialist or a critical care physician. We know about Professor Anand Kumar for his famous study of 2006, where he recommended early antimicrobial therapy. Never after that particular study, a single study could reproduce the same dramatic findings. Any prospective study which could produce the same amount of results, whether early antibiotic administration can have so much effect on the outcome. But definitely, it being a very large retrospective study, still Surviving Sepsis campaign do consider this particular study, and they still recommend an early administration of antibiotic. But we also have to consider what he recommended or what he found in another paper in 2009, 3 years after his initial study, where he found that it was not only the timing of the antibiotic but also the choice of antibiotics. So if you have selected an inappropriate antibiotic, irrespective whether the culture was positive, irrespective whether bacteremia was present, or it's in a hospital or a community acquired infection, the outcome will be likely to be worse in these patients. And there is 5 times higher mortality in patients where you have chosen an inappropriate therapy as compared to the patient where have you chosen an appropriate therapy. And the risk of having a hospital acquired infection, the risk of inappropriate therapy will be higher in patients who are hospitalized, who are in an ICU, where you will likely to choose an inappropriate antibiotic at least 2 times there in the community acquired infections. Another study where they found that likelihood of an inappropriate antibiotic selection is almost in 1/4 of the patient with bacteremia or a bloodstream infection. So at present, how do I choose antibiotic? Most likely, first thing and foremost thing we should consider is whether a patient has an infection or non-infection, whether patient is in shock, the infection is hospital acquired or it's a community acquired infection, whether the patient is having an immunosuppressed status, so automatically your likelihood of having a multi-drug resistant or other opportunistic infection will be high. What is the source of infection? And most importantly, whether I'm dealing with a bacteria, fungal or viral. So you need to consider all these things at present when you start an empiric antibiotic therapy, or you have to wait for the appropriate culture. But at the same time, if you look at this particular slide, probably it tells you that we are dealing with one of the most common infections still prevalent in most of the most of the developing countries of the part of South Asia, like Salmonella typhi. The emergence of resistance in such a common infection has dramatically increased in last 4 to 5 years, and now we are dealing much more high likelihood of a carbapenem resistant or carbapenem, ESBL Salmonella typhi. So we are living in an era where MDRO is a quite common, not just in hospital acquired setting, but also they are progressively increasing even in the community acquired setting. We also know that whenever we use antibiotic, irrespective whether we have chosen that appropriately or inappropriately, we are likely to have a collateral damage. If you look at ESBL, expression by a gram-negative bacteria, it increases almost 4 to 5 times if you use a ceftriaxone on a quinolone. I think the most common combination which we use for the treatment of pneumonia in the hospitalized patients. So if you are using a common antibiotic, even ceftriaxone and quinolone, you are still going to increase the risk of an MDRO in the subsequent infection or to another infection later on. So it's an important to understand, irrespective of whether you are giving an appropriate or inappropriate antibiotic, you are going to have some collateral damage. So it's further important, you have to choose an appropriate antibiotic, not only to make sure that you are going to have a good outcome, or you have to going to have a better outcome for the current infection, but also you will otherwise produce a damage which will be subsequently added with the initial appropriate choice of antibiotic. So we are losing this war. There is no doubt about that. Antibiotics are losing the war. we as a treating physicians are losing the war. And at present, how we choose antibiotic is not just by looking at the bacteria, but how they are producing the resistance. So most of the future generation antimicrobials which we are using, like at present, we are having these newer antimicrobials. So it's very, very important that we need to know what type of bug we are dealing, and most importantly, what type of mechanism of resistance that bug is already having, whether it's a KPC, whether it's an OXA480, or it's an NDM or MBL organism which we are dealing with. And then only we can actually select the right antibiotic for that group of patients. So by this background, how our PCR tests can help and whether they have some role in selection of these antibiotics for timely escalation, timely de-escalation, and most importantly, in antimicrobial stewardship. That at present in the research or in the market, there are two types of tests available. As we know that conventionally how we do a test by after a phlebotomy has been done and a culture has been collected into the Vitek bottle. So after the first blood culture which has turned positive, you do the microbiologist does a subculturing, and then on that subculture plate they do a further gram staining and sensitivity test. So approximately, even if the blood culture is turning positive with a Vitek or a Bactalert, it takes at least 48 to 72 hours by conventional method to get a positive result along with the antimicrobial sensitivity. So here the PCR comes into the play, whether the test is directly applied to the blood culture sample directly after the phlebotomy, where instead of going for the conventional method of Vitek, you are directly applying the PCR assay and doing an identification of the antimicrobial resistance pattern. Then there is another pattern of microarray, which is another method of NAT or PCR, where we have to wait for the blood culture to turn positive, and then subsequently further identification is done from that culture positive bottle. So irrespective of the method, if we use, whether it's a multiplex PCR assay directly from the blood culture bottle or after it turns positive, the turnaround time will be approximately between 7 hours to 30 to 36 hours. So it's still much, much faster as compared to what we are dealing with a conventional way of doing a testing and finding out an organism or antimicrobial sensitivity. So as I said, either we are dealing with a method which is directly looking at the positive blood culture, or there is another method which is directly looking at the directly from the time of the collection of the specimen. We already know about multi-top, where it's not a PCR based test, but it's a spectrometry based test where PMF is identified, and the migration of the PMF we identify the particular organism. This has already been established into the clinical practice, and many hospitals are already using it. So why I've kept this particular test still, so that we in the next subsequent slides I will show you how the evidence has evolved by comparing the multi-top or other standard culture methods with the two new PCR based methods like a Verigene or FilmArray BCID test, which is available through Biomedics. Then there are other tests which are available now directly from the whole blood culture. So these are the tests. If you look, Septifast, Multiplex Sepsis, or T2 bacteria panel, or resistance panel, or Sepsis test. Some of these tests have not yet been validated, and other than Septifast, there is no randomized control trial for these tests, or large quasi-experimental studies are available. So most of these tests are still on the lab and still require validation. But yes, Septifast has been directed and have been used and now been available for clinical practice. If you look at the directly from the last slide where I showed this from the positive blood culture, the sensitivity and specificity was quite high. It's more than 90 to 95% for most of the tests here, versus the tests which are directly done from the whole blood culture. So it's something which need to be considered. The sensitivity from a test which is relatively faster, and one can identify it immediately from a whole blood culture, though the turnaround time is less than 10 hours. But the problem is the sensitivity is very low. Even the specificity in some tests is less than 90%. So what is the current evidence supporting these type of tests, and where are these tests can be used in clinical practice? This particular study where they use standard of care and then further identification after a positive blood culture using a multi-TOF and antimicrobial sensitivity test. So it's a pre and post intervention study which was done in a patients with bacteremia. So post intervention they used or the intervention they used was biofilm FilmArray, which was again BCID1, not BCID2. So BCID1 was the older panel, and they found that time to detection was just less than 2 hours. time to optimum therapy was again significantly low, versus 5 hours versus a 15-hour in their group from pre to post intervention. Resistance detection was almost complete concordance. So this is another key factor which is always something being questioned about these tests, whether they are over identifying the organism or they are missing the organism. So over identification is a very big issue, especially being a PCR based test. So there are high chances you may get a organism which is not present in the blood culture subsequently. So complete concordance in this particular study was identified by them. And as we know that most of the clinical studies where we use NNT or number needed to treat, similarly they identified that for every one test which can change the outcome, you need to do at least 4.3 tests. So approximately one out of 5 tests will be helpful in changing the therapeutic outcome, which is a good number of NNT or number needed to test. Then another common company, as the previous test was done by again Biomedics. So this is another major company which is producing the PCR sulfate. So they have these tests which are carbapenem VSA or expert RV2 carboassay. The study was done, basically it detects almost all type of carbapenems, whether it's OXA, KPC, NDM, or even VIM. The sensitivity is very high, above 95%. Again, very small study where they found nearly 100% sensitivity and specificity, irrespective of the carbapenemase type, irrespective of the blood vials used and the time of incubation. So, but here you are looking, you have to suspect which type of carbapenemase, or you are actually identifying the mechanism of resistance, not the actual organism. So this again a test or a study which they found one can consider for PCR way of method of detection. Then how to use these tests with antimicrobial stewardship. So this is something, as I said, there is always a risk when you use antibiotic or use a prolonged antimicrobial therapy, especially with the empirical choice. We always going to have a risk of collateral damage. So whether we can combine these things along with antimicrobial stewardship, we know that yes, whenever there is a culture which is positive, you will get a chance to time to escalate. But whether the same thing can be used to de-escalate, whether we can club these tests along with the antimicrobial stewardship therapy or antimicrobial stewardship practice. So this particular study where they used pre and post antimicrobial stewardship along with the test in around 800 patients, they found optimal antibiotic therapy increased with each intervention. So in the first intervention, they used only pre-PCR, standard of care with AMS. Then they used AMS without AMS and with PCR. And finally, in last subgroup, there was antimicrobial stewardship where they were actually using the test to de-escalate along with escalation. So they found was when you are using antimicrobial stewardship along with PCR testing, the chances of having an optimal antibiotic therapy increase. You are going to have appropriate selection of an antibiotic, and the time to optimal antibiotic therapy is also decreased with the introduction of PCR, again with or without antimicrobial stewardship. So that way you can not only timely escalate the antibiotic, but also can timely de-escalate the antibiotic if you have a negative culture report available through a PSR. Now, subsequently, Biomedics, they released this Vcid2 panel, again, which has been validated in some studies where they again found sensitivity and specificity of 99.8%. The difference between Vcid1 panel and 2 panel was number of organisms where they are identified. And obviously these, mechanism of resistance, which they have further added, different new mechanism of resistance, like even colistin resistance, NCR1, or vancomycin resistance, VEN-B, VEN-A or VEN-B, even methicillin resistance using MAC-A gene. So there were number of organisms which were added, and also the newer mechanism of resistance which has been added into this new panel. Again, the smaller studies of less than 200 to less than 300 patients, they found the sensitivity and specificity is very high, with a very good amount of concordance with standard blood culture and multi-top methods. Another method which has been used, a combination of PCR with miniature magnetic resonance, where T2 candida test or T2 bacteria. Again, this is specific for an organism where PCR was used to identify these so-called MDR organisms like escape or candida. So ultimately, it turns out to be, when we are working in a corporate setting, whether we are able to justify this high cost, whether you can convince your management whether I need to use this high cost test at present, which is really costly in some of the places. So this particular study, which was recently published in BMC Infectious Disease, where they use Sepsis Finder tool to identify first which are the low risk groups and high risk group patients, depending upon the risk factor score. And they identify the patient who has high risk group, where the risk of mortality is high and the risk of bacteremia is high. The cost of PCR can definitely be rationalized for this high risk group, versus in a patient, if you have a low risk group, so there you can still go ahead with the conventional method. But if it's a high risk group, the cost of PCR in this particular study could be rationalized. Again, the study was done in UK, but yes, this particular study could rationalize the cost, and they could produce the same amount of, or the better outcome by using this test. So finally, the last slide, what is the problem? So where are we, and how these tests can be used, and what are the problems which we can still face? They're a big problem of, as I said, these tests sometimes you give certain amount of results which can be not matching with your clinical scenario, or not having a concordance with the blood culture. So that's still an important issue to be considered, whether I'm dealing with a colonization versus infection, and that's what we deal with our standard culture method. So before starting an antimicrobial therapy, just looking at the culture, we need to always consider whether I'm dealing with a colonization versus infection. Then obviously there are reporting of incident results. As the future generation of these PCR tests has come, as I said, there are few modifications which have already been done to increase the chances, or to reduce the chances of these incidental results, or reduce chances of having abnormal results. So probably I think this is something which is still in pipeline. Probably the future test will be able to reach that high level of concordance with the gold standard, which is still the blood culture. Requirement for experienced operators and dedicated laboratory environment, which can be an issue, though there are now more of POCTs, and at some places these are available directly at the bedside in ICU. And that what, in fact, I feel will save the cost, will reduce the work on the busy laboratories, and again need to be validated as what we are doing for other POCTs. A very, very important factor, you still need to do a culture, even if you have got because you need to have antimicrobial susceptibility data, not just to escalate or de-escalate, but also to further identify further de-escalation course, or for identifying another antimicrobial which can be used subsequently in an oral formulation. So still at present we need to have a paired culture, along with one going for a PCR testing, the other going for a conventional method of testing. So this is again another pitfall which need to be considered. So it's at present I can say it's a very, very important tool which can help us to make a clinical decision making at the bedside, for timely escalation in a patient who is sick, timely de-escalation if there is a negative report, and that will help in antimicrobial stewardship, and also will help to reduce the cost if it's a if you reduce the duration of the antibiotic, then definitely will change the outcome of the patient. So clinical correlation is something need to be still done with most of these tests at what we are doing with our standard way of doing a culture. So the key takeaway point for my presentation today is PCR based tests are fairly accurate at present. They have a good sensitivity and specificity. They are faster, they are cost effective in the management of critically ill patient. They can reduce time to optimum antimicrobial selection, and they can obviously help in antimicrobial stewardship if you combine them as a very crucial tool for early escalation and early de-escalation at the same time. Large randomized studies over clinical outcomes at present are lacking. So this is something which probably future study will look upon, whether using these tests ultimately change the outcome of the patients or not. And currently PCR based on blood culture, as I said, are much more sensitive and have been leading the race. Probably in the future, we will be going towards the test, which will be directly testing or getting the reports from whole blood, and with a higher sensitivity and higher accuracy as what we are doing with as we are getting with the current test of PCR on a blood culture positive bottle. So that's all. Does it help in clinical decision? So at present, I really feel yes, it helps, and it can be used as an important tool while managing these patients at our bedside. Thank you. Thank you for listening.
Thank you very much, Dr. Prashant. I mean, it was indeed a wonderful insight on the topic of PCR-based microbiological assessment and MDR organism evaluation. This is really a need of the hour. Basically, we have been struggling since years together, I mean, decades after decades, and most of the times what we find is like, the microbiological culture reports are invariably the organisms are not identified. And probably PCR-based methods would be more effective in identifying the organisms at the earliest. As far as the time duration is concerned and the early usage of antibiotic can be, advocated at the earliest with the PCR-based techniques. But there are still some fallacies, like, we have been seeing unnecessary polymicrobial growth in the culture reports with the PCR based. It becomes very difficult at times as to whether we should rely on these culture reports or not. So, as you rightly said, I mean, we should have a backup with the routine culture reports, which is going to take time, maybe 48, 72 hours the culture reports are available. But early institution of antibiotics can be advocated as far as PCR-based diagnostic modalities are available. So, but how do we differentiate this polymicrobial false positive and false negative organisms? Over to you, Dr. Prashant, and I would like to ask the same question to the panelists also, and I would like to hear from them as well. Yeah.
Thank you, Dr. Akhilesh. I think it's a daily clinical dilemma which we need to answer still, despite these PCR tools. So I always take what type of test you are doing and what type of clinical setting you are dealing with. So depending upon that, the type of sample, though my whole talk was focused on the bloodstream Vcid2 panel, which is basically for a positive blood culture. So you are dealing with so-called a sterile site. And obviously, if a positive report is available in a patient with sepsis, that's the way I continue to, or I decide the choice of antimicrobial depending upon the report. But if you are doing a respiratory panel, which is another common PCR panel, or a CSF, not CSF, but another GI panel, there you need to make a decision at the bedside whether I'm really dealing with a colonization or it's a real infection, which is the reason why the patient is in sepsis or in shock. So that sterile site versus unsterile site. The second is whether the patient is really fitting into the clinical picture of sepsis, and that's what we need to do. Even if a culture is positive, irrespective whether it's through PCR or from blood culture or for tracheal culture, the ultimate decision is whether it's a colonization you are dealing with or an infection you deal with. If it's a colonization, definitely, even if PCR is showing, the way you will discard it as very similar to what you are going to discard another, the conventional culture. But if it's a patient who is in sepsis, patient is in septic shock, and it's a sterile culture, or if you are fitting up a patient who can have an MRSA, then definitely this is something which will be helpful. Another important part which we don't get from the culture is what type of bug, which I try to show. At present, most of our antibiotic selection is not just on the bug, but also what type of mechanism of resistance. Unfortunately, most of our current tests do not give that data. They only tell us the sensitivity with MIC value or a breakpoint, but it doesn't tell you whether I'm dealing with a KPC or I'm dealing with OXA. So obviously, in a place where if you are dealing with an MDRO, whether I need to use a ceftazidime avibactam or a ceftazidime tazobactam. So that decision, obviously, these tests can only help.
Yeah, fantastic. I would like to hear from Dr. Abdul Kapoor and Dr. Pragyan and Dr. Divya and Dr. Vasan Nagvikar also can throw some light, and your experience also would like to hear from you all about PCR-based therapies. Yeah, thank you.
Yeah,
So,
I totally agree with Dr. Prashant. Actually, most difficult one a respiratory panel, and when we need to distinguish between commensal versus infective. And what is happening, like in my ICU, most of the bugs, commensal or infective, both are Klebsiella. So that makes it very difficult. So if my ICU is most often harboring like commensals are coming Klebsiella, if it comes some like a pseudomonas, then my eyes are open, it must be pseudomonas. But as most of the cultures are growing Klebsiella and most of the colonizers also growing Klebsiella, then there becomes a problem. So we need some mechanism to distinguish between a common organism that is found in ICU to distinguish whether it's a commensal or a genuine infective case. If it is something other than what we found in normal in our ICU, then it is easier for us to pick up. I think Abdul sir and Dr. Divya can highlight on that.
Yeah, I think if I have few one or two questions basically to Abdul sir and Nagvikar sir. So basically, in which context we have to use this test? Like a patient who is presenting in the ED with severe septic shock, and initially you have to send the test, or should we wait for the cultures? And if the patient is not responding to antibiotic, after that we have to find the particular organism for the antibiotic resistance. or is it useful for the hospitalized patient who developed hospital-associated pneumonia or any nosocomial infections, rather compared to the community-acquired infections? And if we have the facility, whether after 2 or 3 culture negative reports, can we send this kind of test? So what is the take home from the Nagvekar sir and other panelists? That is what my questions.
Dr. Gafoor sir, I mean, if you are available, can you please?
Professor, you're
Like-
muted.
Yeah.
You're muted.
Yeah, good evening.
You're not audible, sir. You're not
Sir,
audible.
Gafur sir, you're muted actually.
Is it okay now?
Yeah,
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 hear
yeah.
me now?
Now you're audible. You're audible now.
Out of all these rapid PCRs, the one test that could be useful will be the blood culture panel, whether the biomarase biofire or carba RPCR. I think the biomarase panel, the biofire panel for the blood culture is promising because it's got acceptable accuracy. And if you get the sensitivity panel, sensitivity data 24 hours earlier, that it will make a significant difference in the outcome, and probably much more than the outcome, the cost of antibiotic care. We all deal with carbapenem resistance on a daily basis. And if a patient is on a BLBLI or a carbapenem or an inotrope, we automatically add colistin. And what's the cost of colistin? Definitely 7,000, 8,000 rupees a day. Yes, carbapenem, cheaper brands are available. We can get carbapenem 1 gram for 500 rupees. And it's a good. So 1,500 rupees for carbapenem, a low-cost carbapenem. But colistin, whichever brand we use, the cost is high. So compared to the cost of antibiotic, especially a cost of a combination of antibiotic, is going to be more than the expected cost of a PCR panel. So again, depends on high-risk patient or low-risk patient. If you use a PCR panel for the blood culture PCR panel in a high-risk population, like our intensive care population, it's probably will be cost-effective. It may change the outcome. We need additional data on that, but we can definitely rationalize the antibiotic based on the available data, mostly done in Western countries. The BioFire 2 looks like good accuracy. Regarding the Carba RPCR for the Sepsis, until a few years ago, the accuracy was low, especially for detection of certain types of OXA48, but they changed the panel significantly after that. And of late, the accuracy of the test is expected to be good. I don't do that routinely, but it looks like, as per the recent data, by the Carba RPCR looks good. And again, is it useful for initiation of antibiotic? Yes, could be initiation of antibiotic or change in antibiotic, but I don't know how useful these PCRs are for stopping antibiotic.
Sir, many studies have shown that like Malditov along with the PCR-based test, sometimes used as a complementary, you identify the species with Malditov and do the antibiotic resistance pattern with this PCR-based test. So how feasible and what is your take, sir, on this?
It's very feasible. It's very feasible. And with identification itself, we can get with these PCRs. But of course, Malditov is the best for identification of the organism. Along with that, we can do the PCR test. It's good. But just now, BCID, I saw in your slide, the colistin resistant gene of the Vcid panel is MCR1. It's extremely rare for our clinical colistin resistant isolates to have MCR1. Most of our Klebsiella, colistin resistant bugs are Klebsiella, and Klebsiella, rarely MCR1 is the resistance mechanism. MCR1 is a plasmid mechanism, and most of the colistin resistance isolates in our clinical setup around the world have chromosomal mediated MGRB or other mechanism. So unless biomarker include at least MGRB into the panel, I think we are going to miss 99% of the colistin isolates in most of the countries, including India.
Sir, what is your take on Nagvekar, sir? Is there, sir? Sir, if Nagvekar, sir, is there, can he?
Not in the network, yeah, but we'll try to connect him.
And sir, certain tests are also recommended, like doing antibiotic stewardship with PCT-based therapy along with the multiplex PCR assay for antibiotic resistance pattern. So is it a good modality of antibiotic stewardship program? Means according to you, sir, or Dr. Prashant or Dr. Pragyan?
As I showed, there are few studies. Again, the data is very small. These are just pre and post intervention studies. Again, as I said also in my slide, and Dr. Kapoor also mentioned, there are no outcome studies which have been done with any of these tests so far. At present, the focus is primarily to decide the concordance. So they are just validating most of these studies with the blood culture. So that has been done. So there is fair amount of accuracy with especially the blood culture BCID BioFire 1 or BioFire 2. Second part was whether we can actually select the appropriate or optimal antibiotic selection. Again, there is now a good amount of studies showing that, yes, it could be another important component of AMS, which can be decided by using these Vcid1 or Vcid2 panel. The final part is whether we can de-escalate. There are a couple of studies where they actually use the test to de-escalate. If you are not getting a positive report, whether you and the patient is responding, there is no risk factor, there is no further worsening, you can safely de-escalate.
Only thing about de-escalation is that I remember that beautiful slide which showed that cost effectiveness of this test only implies in very high risk patient. So de-escalation again cost factor adds up. So most of the severely septic case, sepsis, septic shock patients, if you do this test, it's cost effective when you compare to routine culture. But regarding de-escalation, that will be an issue in setup.
Though that particular study was not about de-escalation, the whole purpose was to justify whether you can identify a subgroup of patient where you can justify the cost. So by using their that Septifast test, what they was doing is low risk group and high risk group, identifying based on the risk factors, and then that high risk group, obviously the chances of getting a positive blood culture and a poor outcome will be high in that high risk group. So they could justify the cost of using a PCR test in that high risk group, because obviously your chances of first of having a positive blood culture and then subsequently PCR will be useful to identify the organism.
And if
more studies to prove de-escalation.
Yeah, I agree. No doubt about that.
And particularly which subset of patients this is very useful, like a patient with meningitis or a patient with ventilator-associated pneumonia or a patient with severe bloodstream infection, like CRE organisms. So where the sensitivity is more, sir? Any such data or?
Sorry, the question is to
like a patient with meningitis or a patient with ventilator-associated pneumonia or a patient with severe bloodstream infection with CRE organisms. So where the yield is more, the sensitivity is more to detect the organisms in such test.
Okay, I think it's another important way, that CT value, as we are using CT value for the COVID. So that become much more fashion. So that has also been tested whether the so-called yield. So, but again, if for a blood culture, it doesn't matter. If you have a test which is showing a positive from a BCID1 or BCID2 panel, you have to treat. I don't think we can escape with so much high sensitivity and specificity if you get a positive report. But yes, this will be useful in a panel which has been taken from a respiratory site or a GI panel. Hello. Yeah, so there probably CT value have been they have been few studies, very small studies, where they are using so-called CT value to identify the yield, the way we do it with the tracheal culture or a bronchoalveolar lavage by getting a colony from CFU or more than 10 to the power 5 or more than 10 to the power 6. The same way, the lower the CT value if you get from that particular site, that will increase increase the sensitivity from a positive culture from that place.
And my question to Kapoor sir and Dr. Nagwekar. Do you feel, sir, the recent T2 bacteria test, T2 MR test, which is I think the recent generation of tests from the biomedics, can it change the further outcome in sepsis management compared to the multiplex PCR?
Personally, I have got no experience with T2. Because we need our own data, and I haven't read any Indian data.
So basically, T2 weighted MRI this thing assessment is basically for fungal infections. I'm not sure about its usefulness for bacterial MDR organism identification. I'm not sure about that, but there are some centers where T2-based MRI assessments are also available.
No, I think there are fewer studies only, like T2 Lyme and T2 bacterial disease with T2 fungal disease. There are very few papers, but of course it's not practiced in India. So I just out of the curiosity I asked, because sir is the best person to answer these things. So if it is a future prospect, so why not to study about it? That is the only thing.
The advantage with the T2 assays will be like early identification. It is much more faster than Multiplex and faster than even PCR identification. Probably within 30 minutes or within 1 hour, the test results are available. That is the only advantage. But I think we need to know a lot more about assays.
And what about the cost factors? A lot of centers are basically they are complaining that the cost is used, and sometimes it's basically non-affordable, and that is the reason they are not able to send such type of test. So, is it going to indirectly affect the outcome, or indirectly going to affect the economics of the patient management?
The money is a big issue, especially in the era of MDR and combination therapy. If you look at the cost of, if you use the original brand of Meropenem, it's going to be 7,000, 8,000 rupees. Colistin is going to be 8,000, 9,000 rupees minimum. And we need to give, for example, my febrile neutropenic patient, I need to add gram-positive coverage, antifungal coverage, and the cost is going to be 40 to 50,000 rupees a day. And if I'm going to start a multiple antibiotic and an antifungal for a severely septic febrile neutropenic, I can definitely I prefer better do a PCR, which will give you a faster identification and sensitivity, where I can narrow down. With the high resistance rate, I need to give broad spectrum coverage, but we do come across with sensitive bacteria as well. And if we get an identification and a sensitive to a first line antibiotic or a second line antibiotic, I can sharply narrow down the antibiotic coverage, where cost is not going to be an issue. At the same time, it's not worth doing a patient who is stable in the ward. We're sending a blood culture after admission. I don't think immediately asking for a PCR on that positive blood culture is going to be cost effective, because this patient is not going to be on colistin anyway. This patient is most likely going to be a piptaz or sulfosalbactam, where I don't think the test is going to be really cost effective. ICUs, especially in oncology settings, transplant settings, and ICU patients who are on inotrope, is worth doing the PCRs.
Thank you, sir.
Sometimes we get a polymicrobial result also. We get multiple organisms on the PCR. In that case also, then the cost effectiveness becomes an issue.
For a blood culture, for a blood PCR, if we get a polymicrobial identification, and anyway, see, differentiation between colonization and infection is a clinical decision. Yeah. Whether it's a culture or a PCR. Yes, it's more applicable for a PCR, I agree. But if you get a polymicrobial result for a blood culture, and if the patient is at risk of these organisms, again, clinical decision, you treat. At the same time, I'm not a big fan of sepsis PCRs of respiratory tract. I rarely do that. I do that, especially for virus. For my oncology patients, I'm more concerned about the virus than the bacteria. Bacteria, I'll get a culture results next day, but virus, I'm not going to get that. I do the diarrhea PCR for my chronic diarrhea patients, especially bone marrow transplant patients. It's very useful. Even if cultures are negative, I identified many viruses and even bacteria, including Campylobacter, with these PCRs. It's a good test for PCRs, a good test for meningoencephalitis. Correct. Apart from the sepsis, yes, blood culture and then PCR for high-risk patients could be worthwhile.
Yes. Sir, there is one question in the chat box. Basically, one of our microbiology, Dr. Dipti, has asked, basically, whether it is a biofire or it's a Multiplex. Which test you prefer, sir? Or other panelists, sir? Can I answer?
Okay, I think multi-top is basically to identify the organism. You will still not get the sensitivity. You will still not get the mechanism of resistance. So biofire is not only identification, but also you will get a, especially if you are talking about BioFire, not just any other PCR. If you're talking about BioFire, yes, you will get the mechanism of resistance along with the, the organism. So it's not only the, the right antibiotic which will you start at the right time, but also an appropriate as per the mechanism of resistance.
Yeah, thank you. So another question from our delegate. Basically, he wants to know that whether in respiratory term, does it help to identify the MDR, XDR, or total drug resistant bacteria? I think already Dr. Prashant has described beautifully in his lecture. So there is no doubt about it. It definitely is the superior test in diagnosing the MDRO. And another question is, sir, what is your take on the colistin resistant organisms, sir? Nowadays, a lot of these colistin resistant organisms are growing. So is it that sensitive in picking up the organism and treating the patient, sir?
I think Dr. Abdul mentioned very nicely. Dr. Kapoor already mentioned, the current BioFire is only giving MCR gene. So at present, the common mechanism of resistance which we are dealing with colistin is not available. Probably the subsequent generation which will be coming, they will incorporate the gene, and they're working on that. Probably that's what I had an interaction a few weeks back. But at present, the what you will get is probably an Acinetobacter. But whether it's colistin sensitive or colistin resistant, you cannot completely rely on BioFire 2 as such.
So I don't think we have any more questions. So definitely, it's very...
Can I ask one question? I'm Dr. Subhadeep over here.
Okay.
So my question will be kind of to all the panelists over here. We'll kind of very practical kind of questions. Suppose somebody has come with a septic shock in the ER. Normally we send a routine cultures, 2 sets of blood cultures, and we give antibiotics. So there is a kind of routine protocol that we follow for all patients who comes with a septic shock in the ER. So how feasible and how practical is it to send a PCR-based assay in the ER to identify quickly identify the organism in somebody who has been recently admitted with a septic shock in the ER only? So just like we said, a culture in the same setting, whether it should be routinely sent, this PCR-based culture should be routinely sent, because nowadays what we see, even in this community setting, somebody with a community acquired infections also sometimes they come with MDR bacteria or MDR genes they are associated. So is it possible? Is it feasible? Is it practical? And how? What are the financial implications of all these things?
Okay, I think what we do in our ICU, patient who is being admitted in intensive care unit with a sepsis or septic shock. So it's the paired blood culture, as you said, but we tell it to the lab. As soon as the positive blood culture is available, then it is the point where you will be telling them to apply for BioFire or not. So first thing is culture is turning positive or not. Once it is turning positive, as soon as that alarm is there, I do in my ICU for critically ill patients, as Dr. Kapoor said, not for patients who are out of ICU, patient who is definitely in shock, the patient who has risk factors for an MDR, that's the patient I will consider to get a BioFire done immediately as soon as I get a report from the lab. The test is, the culture bottle is giving an alarm of positive, rather than waiting them for a subculture and gram stain and the conventional method.
Suadeep, I think it would be more feasible if the patient is high risk and there is a suspicion of MDR organisms. In that case, it would be more feasible to directly do a PCR-based assay, probably.
Yeah. And there are other 2 questions. It's difficult to find people who do Carba test or kit. Any guidance on that respect? Somebody has asked. And the other question is, blood culture flag positive is required. So in ER only, blood culture is required. Is it, in your opinion? So every time you have to draw a culture and do the culture bottle test, and then followed by the this rapid test of multiplex PCR.
Sorry, can I get the question again?
Yeah. So the question is, if the blood culture flag positive, so every time you need a culture report to be flag positive for the multiplex PCR, or you can directly detect from the blood, which is...
Okay, the BioFire is only from a positive blood culture. It's not for directly from the blood culture bottle. It has to be positive, then only you apply a BioFire panel. Okay, so that is one. I think the other question was you need
The
to
other
do
question
blood
is
culture.
the panelists want to know the guidelines, because nowadays the expert Karwar kits are sometimes they don't get in their hospital.
Mhm.
So what is the best alternative for them?
I don't have a knowledge. Maybe Dr. Divya can add.
Kits are not available actually in all the
Yes.
hospitals. Kits are not that easily available. But if it depends on the institute. If we have a practice definitively of using, then we can make it available.
Where is Dr. Nagwekar? I can't hear his voice at all. He has
Sir
joined.
Yeah, I think sir, I don't. Where is sir actually? So, at least can you call up sir and just you can ask.
Yeah, I'll try.
And sir,
There are a
another
few questions.
I just want.
yeah, sir, another question for just for the sake of asking, basically, sir. So, what is your treatment protocol for MDR or colistin resistant bugs, sir, nowadays? Because we are getting a lot of colistin resistant from, in fact, in other hospitals, sir.
Yeah. See, I work in an oncology center. So of course, you know, when I did a carbapenem stool screening 4 years ago, 1/3 of the new referrals to our hospital stool screening was with carba-R PCR was positive for carbapenem resistant. That means 4 years ago, my baseline rate of carbapenem resistant or the patients walking into my hospital, of course, they are coming from 5 other hospitals, they are cancer patients, was 1/3, 33%. And that was 4 years ago. And then we did a carbapenem resistance stool screening of healthy volunteers for Mumbai, Chennai, and Hyderabad. 4 years ago, the rate was 7%, healthy volunteers. So we are dealing with, all of us are dealing with high baseline carbapenem resistance in community and in the hospital. Colistin resistance is increasing in all the hospitals. And so whether we should give empirical coverage for colistin resistance or not depends on the patient population. My patients are acute myeloid leukemics or ALL patients coming back for the chemo again and again and again. They're at high rate of carbapenem resistance and even colistin resistance. But you know, if you look at the experience, there was an exponential increase in colistin resistance until a few years ago. And that tendency is plateauing, at least it's not as rapid as earlier. But still, colistin resistance is a problem. But what antibiotic use for colistin resistance? You know, ceftazidime, avibactam, some of the isolates, a combination of ceftazidime, avibactam, and with astriona is useful, but not all the isolates. Some of the isolates of colistin resistance are also resistant to ceftazidime, avibactam, and astriona combination. Chloramphenicol is one option I use. Many of my isolates are chloramphenicol sensitive, some of the fosfomycin sensitive. We go for a combination of these antibiotics if colistin is resistant. Anyway, depends on your patient population. But routinely, we don't have to cover for colistin resistance unless you detect colistin resistance or one of the genes are positive. And as we discussed already, MCR1 is literally useless in our clinical practice. When we did a detailed molecular analysis of colistin resistance of clinical isolates, a very minority of the isolates, colistin resistant isolates, are because of MCR1. I really don't know why bioMRI added even that MCR1 and not thinking of chromosomal mutations into a panel. Maybe it's difficult to include, or maybe they're planned to include.
I think sir has joined.
Dr. Vasant has joined, I think. Gunadhar, you can ask the final rapid big question to Vasant, sir.
Hi, Gafur, sir. Vasant.
Yes, sir. Hey, Vasant.
Hi. Sorry, sir. Some misinterpretation of timing and all that.
No, Vasant is a very busy consultant, you know.
Sir, welcome you to the group, sir. So just want your opinion regarding the multiplex PCR compared to the along with MALDI-TOF or versus the blood culture. In which subset of patient you would like to use the multiplex PCR, and what is your take home on that, sir?
You mean to say multiplex PCR in the Vcid panel, right?
Yes, sir. Yes, sir.
Yeah. So I think if your patient is hemodynamically very stable, and if you know the which is the syndromic diagnosis, like if you know that this patient is UTI coming from the community. But I'm just giving an example. The patient is coming from the community and got a pyelonephritis, and the blood culture is flagged as gram-negative bacilli. And then the question comes, should I go in for a BCID panel early, or should I wait for the conventional culture? Because BCID panel will cost you around 15 to 25,000, varying from hospital to hospital. In this, if I'm very certain that I'm dealing with pyelonephritis and I know that the most likely organism would be an Enterobacteriaceae, and I know the pattern of resistance in the community is ESBL, 80 to 90% ESBL, and I'm not expecting a carbapenem resistance pathogen here, then I will not do a BCID panel. I would go, and the patient is hemodynamically stable, I would go with the conventional cultures and continue the treatment. But if there is a patient in the intensive care unit who has been there for a long time and gets septic, okay, or new onset sepsis, and this patient, say for example, has been there for 15 days, and the most common would be the line-related sepsis, or it could be COTI, whatever it is. Your blood cultures are flagged gram positive, gram negative. Predominantly in India, you'll see gram negative only, unless your patient has received a lot of gram negative antibiotics. Then you'll see because of the overgrowth of gram positive. But say in the ICU, if your blood culture is flagged gram negative, there possibly I would go in for early BCID panel, because identification of the pathogen would be important here. Of course, your treatment would be colistin-based therapy, but it is possible. Many times what happens is patients have received colistin, say 10 days back, 4 days you stop colistin. Patient is doing well, but has a central line for dialysis, catheter and all that, and develops a sudden onset, new onset sepsis. He's on a couple of inotropes, and the blood cultures, you have started him again on colistin and say high dose meropenem, or colistin and phosphomycin, or colistin and ceftazidime bactam, whatever combination you started, or colistin minocycline, whatever. So in that case, I would definitely like to know the BCID panel, because the BCID panel is, the importance is that it will, if it is positive, it will definitely tell you the organism. Whether it's Klebsiella, then it will also tell you the pattern of resistance of Klebsiella, because BCID2 will tell you about whether it's NDM plus OXA, or it's only OXA 48. If it's E. coli, it will tell you whether it's NDM or not, because predominantly E. coli is NDM. And whether it's Acinetobacter. Pseudomonas is not very common in our community so much. So also a negative BCID panel with a gram-negative bacilli, okay, in the blood, with a prior colistin exposure will also help me a lot. A negative BCID panel also helps me a lot, because I know the organisms gram-negative, which are common ICU pathogens, which are not covered in the BCID panel, are Elizabeth Kinge, which is also known as Chrysobacterium septicum. This organism I should owe it to Dr. Kapoor sir, because I have learned this pathogen chryso from sir only when I was doing my ID at Apollo. So always keep shouting, sir, chryso has come, chryso. So that is one pathogen. And second pathogen is Burkholderia cepacia, which is not covered by the BCID panel. So these two are important gram-negative pathogens. Even if you have negative BCID panel, also will give you a lot of importance, saying that gram-negative most likely in a prior colistin exposure would be a B. cepacia, or it could be a Chrysobacterium indulgens. So that is, so I think a positive as well as negative. But if I'm very certain what is the pattern of resistance, the patient hemodynamically stable, like I told you from the community acquired, it would be of not much importance. I'll give you a couple of more examples. I had a patient who was on COVID, and then he was on a lot of antifungals, micafungin, and a lot of antibiotics received. He had chryso and all that had come. But then once on micafungin 150 milligram daily, the blood culture grew yeast. And so now I wanted to know, okay, what could be the yeast which is growing on micafungin, okay? So I did a BCID panel, and the BCID panel, I know it shows Candida auris, it shows Candida glabrata, cruzi, albicans, tropicalis. I think these are the things which shows. So the BCID panel came negative. So then I knew what is the bug. So negative means I know that the yeast which is there in the BCID, which is not covered, is the Trichospora and the Geotrichum. So I got my answer. I knew that this micafungin is not a drug of choice. I had to switch over to azoles. So I put the patient on azoles. The next day the BCID came as Trichospora. I'll give you one more very quick example. The patient is still in Nilavati. He came from the community, and he had URTI. He is a post-renal transplant patient, and he had cough, cold, and all that at home. Somebody had started him on amoxicillin clavulanic acid, but his cough was not improving. Finally, came to the casualty. By the time he came to the casualty, he was intubated and he had to be put on the ventilator. High supports, 2 or 3 inotropes running 40 degrees centigrade, and he had multiple hospitalizations in the last 1 month, I think 6 months time. And the prior blood cultures in him were Klebsiella, which was, I think, Oxa 48 possibly. I'm not remembering whether it's Oxa or Oxa Indium. But anyway, he had received Zevicepta Astronam that time. So this time also patients comes. So if I ask you, what will be your choice? Suppose if this, retrospective asking, your patient was been a post-renal transplant in and out of the hospital, not on dialysis, doing stable from transplant point of view, had CRE in the past, blood culture CRE, and now comes with URTI and then suddenly is on the ventilator, 3 inotropes. So what would be your choice, if I ask you?
I think Dr. Prashant can have an take on this.
Yeah, so I think what I did was, basically I thought this must be a CRE only. So I did put this patient on, again, colistin plus, I put this patient on phosphomycin for some reason, because I thought he could be UTI, because he was a transplant patient. So I thought he enterococcus or something. So I put the patient on colistin and phosphomycin. The patient's counts were very high, 25,000. Creatinine started rising up. Patient went on dialysis and, sorry. Can you hear me? So
Yeah.
patient went on dialysis and the patient's fever was just not coming down. It was just 40 degrees centigrade. It was just continuous fever. Patient was worsening. After 24 hours, there's very minimal marginal improvement, hardly anything, meaning nothing much. But the fever 48 hours, and then the blood culture grew GNB. So I was quite excited. What could be the GNB? I thought it must be a colistin resistant pathogen. And the Vcid panel grew H influenza. Believe me, friends, I switched over to ceftriaxone and meropenem half-heartedly because he was a very high-risk patient. I stopped the colistin phosphomycin. In 48 hours, the patient was completely afebrile. He was off dialysis in another 3-4 days, off inotropes. His tracheostomy, we had to do his tracheostomy because he was almost 130 kg patient. So these are some important examples which has really changed my mindset, and I use it quite frequently. But if I'm new, that because it's expensive, so sometimes you may have to weigh cons, whether it's community acquired or hospital acquired. Predominantly hospital acquired, I will not, because most of them hospital acquired, the patients are new onset sepsis, they're sick. So these were a few examples which really changed my mindset. When Vcid I thought was very useful in clinical practice, but yes, you have to judge it properly and do it. I hope this helps you.
Yeah, thank you, sir. Thank you. I think there is one more questions from the participant. They want to know what is your what is the take on Zevicepta versus colistin for the carbapenem resistant enterococci, and can this test be used as a marker to identify such organisms?
Meaning BCID?
Yes, sir. Yes, sir.
So BCID panel, we have to understand that ceftazidime avibactam or ceftazidime avibactam plus astronam is a very, very narrow spectrum drug. Okay, it's a very, very narrow spectrum drug because ceftazidime avibactam will cover only your Oxa 48 Klebsiella, and ceftazidime avibactam plus astronam would cover your Oxa 48 plus NDM. But you have to understand that you have to demonstrate susceptibility to this. 99% it will work, but for a Klebsiella which is NDM plus Oxa, I think you have to demonstrate susceptibility. But I would still go ahead with TK. If it's a Klebsiella NDM plus Oxa, possibly ceftazidime avibactam plus astronam will work. And important thing is both the drugs have to be given simultaneously, not in the same drip, in a different drip, but simultaneously. So it's a very narrow spectrum drug. Maybe it will work for E. coli also, or it will work for your Enterobacter also. But again, it's a very narrow spectrum drug because it works only against the Enterobacter. Colistin is a very broad spectrum drug which works for all your carbapenem resistant organisms. So there's a difference between a CRE and there is a difference between a CRO. CRO means carbapenem resistant organisms, which include Klebsiella, E. coli, Acinetobacter, and Pseudomonas. Whereas CRE is only Enterobacteriaceae group. So your ceftazidime avibactam is a very narrow spectrum drug. Never use it unless you have demonstrated the at least the pattern of resistance. But more important is the susceptibility, because even if it is OXA48, the use of ceftazidime avibactam has been so much that over a period of time you might see ceftazidime avibactam resistance also. So I would request you use it, but see that your microbiologist demonstrates the susceptibility to ceftazidime avibactam with the either the strips or by the disc method. So that's very, very important. So that's my take-home message on ceftazidime avibactam versus colistin. Colistin is a very broad spectrum drug. If you do not know the hospital-acquired pathogen, what it is, I would tell you to use colistin, because Cevicepta, you might go 75%, 75%, 75, I would say 3 out of or 2 out of 3 or 4, you might go wrong. So choose colistin or polymyxin B if you do not know the bug, because ceftazidime avibactam is a very, very narrow spectrum. I hope this answers your question.
Yes, sir. Yes.
Oh, yes.
And
Thank you very much.
the last question to you, like we have already discussed, the options for colistin resistant bacteria.
So very important question. So when you say colistin resistant bacteria, there are two types. One is breakthrough colistin pathogens, which I just spoke about, like Burkholderia cepacia, Chrysobacterium indulgens. You'll have Stenotrophomonas maltophilia, or you'll have Morganella morganelli, or you'll have Proteus. So these are colistin breakthrough pathogens. The drug of choice would be either Bactrim or it would be minocycline. Then there are, your colistin resistant, ongoing resistance, that is exposure to colistin to Klebsiella or E. coli or your Enterobacter or Pseudomonas and Acinetobacter and developing colistin resistance. So I think it would be depending upon what's the pathogen. If it's Klebsiella and E. coli, you have at least ceftazidime avibactam plus aspirin. If it is Acinetobacter, maybe you use high dose, minocycline maybe in a higher dose. But I would still combine with colistin, maybe for synergistic action. For Pseudomonas, again, I think possibly colistin I would continue with, maybe high dose meropenem or dolipenem high dose, and nowadays I think the new drug biapenem, not much exposure to that. But a drug which we are looking for Pseudomonas is ceftazidime tazobactam, and a drug which will take care of resistance of all the pathogens which you have colistin resistance would be cefiderocol. That's a 4th generation cephalosporin which will work against MDR, Klebsiella, E. coli, Pseudomonas, and Acinetobacter. So that is what we are looking for. So this would be choice, but in absence of ceftazidime tazobactam and cefiderocol, you might juggle around with these medications. You will choose Ceftran, which is 20% of the time sensitive, and as Ghafoor sir said, chloramphenicol, that would be another option, but very important to demonstrate the susceptibility.
Sir, one question is asked from a panelist, like all these emerging bugs are being covered in this panel, sir? All these atypical organisms are covered in the Vcid panel?
I told you that Burkholderia cepacia and Chrysobacterium indulgens is not covered. Even your Morganella morgani is also not covered. So there are some pathogens. But again, I said that many times the Vcid panel, even if it is negative, it helps me to at least clinically judge what would be the organism. And to differentiate between whether it's a Burkholderia cepacia, like we had a patient recently who had colistin, it grew gram-negative bacilli, and there was a prior colistin exposure. So the Vcid panel for the gram-negative bacilli was negative. So I knew that it is most likely Burkholderia cepacia or Chrysobacterium, so which doesn't have the panel. So you can do an oxidase test. So if your oxidase test is negative, then it is Chrysobacterium indulgens. If your oxidase test is late positive, then it is Burkholderia cepacia. So that way, you can be able to judge it what would be the likely pathogen.
Thank you very much, Nagvika sir. I mean, it was wonderful insight from your side as well. And with this, I would like to conclude the session and multiplex PCR based assays are very useful as far as identification of the organisms are concerned, especially in high risk group of patients where your treatment strategy is going to be very decisive, and it can be complicated if the patients are not identified earlier. So, but the clinical correlation is also very important, the radiological correlation, and your antibiogram and probably your most prevalent organism in the ICU, you should have the assessment of all that. So, but we should use all these tools together to identify the organism. So sometimes we completely focus on bacterial infections, but there may be a viral infection. But PCR-based techniques will be very useful to identify the organisms also, and the treatment can be stratified. And anything else would like to? I would like to request all the panelists to summarize at the end briefly, in 1 to 2 sentences, so that the students can have better understanding of the PCR-based techniques also. Over to you. I mean, Dr. Pragyan, from you. I mean, if you
Yeah,
can
from my
summarize.
side, coming to number one, what you need to consider while using the test. One is the type of patient you are utilizing and the cost factor. More importantly, you have to individualize the case. As we heard from Abdul Kapoor sir, Vasant sir. So you have to individualize where we are dealing with. Are we dealing with a septic shock patient in the ER, or are we dealing with a nosocomial sepsis 3 days down the line after staying in the ICU? Is the patient in high dose of inotropes? So you have to individualize at the present junction when cost factor is high. We have to individualize each case and decide whether this test need to be sent or not. And as Dr. Vasant told, positive and negative test have to be rightly interpreted. That's all from my side.
Dr. Prashant, from your side, small
I
take
think,
message.
yeah, thank you, Akhilesh. There is an important message, which is, we need to use these tests with the clinical correlation, with the clinical setting, as what we were doing with any other blood culture. But yes, the cost should not be deterrent, when you are talking about the outcome, and especially in a patient who is in ICU. Yes, the patient selection at present will be always required when you have to justify that higher cost, but that will depend upon, what type of patient population you are dealing with. And the important thing is the condition of the patient itself. Do you have that time to wait for a positive blood culture, or you need that early identification can change the outcome of the patient? So that we need to always consider before getting deterred by a cost.
For sure. Thank you very much. Dr. Abdul Kapoor sir, can you highlight your take-home message?
It's worth exploring the usage of rapid diagnostics in our clinical practice. But the tests available today probably will be useful. The blood culture panel will be very useful. And as a sepsis test, I don't know how other site panels are useful, but they have their own utility in specific clinical settings. But whatever available test today is worth exploring further, because there is no wonder test is going to be available in the next few years' time. Because I'm one of the jury members of the Longitude Prize. This is a £10 million prize for a rapid diagnostic test. That means if you can identify the organism and the sensitivity within half an hour, but directly from the sample, you can win £10 million prize. And now last 5 years, we had hundreds of applications from teams and scientists across the world. We couldn't give the award to a single team. So now, from next month onwards, we extended that to 1 hour. I don't know if we will be getting a wonderful diagnostic test or not, but most of them are not PCR-based tests. We don't consider PCR as a breakthrough methodology. We are looking into modalities and ideas far beyond PCRs. So we don't encourage even PCRs, but what we have today is based on PCR, and it's definitely worth exploring further, especially for people who can afford it, patient population who will really benefit from it. Thank you.
Thank you very much. Dr. Divya, you would like to have some concluding remarks? Dr. Divya?
Definitely, in the right patient, like high-risk patient, immunocompromised patient, when we get the results in the first 4 to 5 hours, if we get a sensitivity so early, then that will definitely help in the antibiotic stewardship. and that eventually the cost of the antibiotics that are used, that will also go down. And saving antibiotics, I think having better antibiotic stewardship is the need of the hour at present, looking at the colistin resistance and all the other problems. So definitely it is very useful in particular subset of patients.
Thank you very much, Divya. Dr. Vasant Nagwekar sir, would like to have concluding remarks?
I think as I discussed, I think Vcid panel, the Vcid2 panel has been very useful because it not only helps you when you're sick patients with sepsis and septic shock to identify the pathogen. Also, it tells you the mechanism of resistance in that subset. It not only tells you about the gram negatives, but it also tells you about the gram positives, and also tells you about the various Candida species like Oris, which is a major concern now. So if you know it's a yeast and Oris, then also I think definitely it's useful. But if it's a community acquired pathogen, then possibly I will restrict my usage. I will use it more for hospital acquired pathogens for those people who are sick and septic shock, because finally the money counts here when you're doing a Vcid panel.
And we should not forget that there are false positives also, but the clinical correlation is very important, whether that bug which is identified is really causing problems or not. So we should be able to differentiate colonizer versus the true infection. So yes, with this, I would like to conclude this session, and I thank you all. I mean, Dr. Prashant, Dr. Nagwekar sir, Dr. Dulgapur, Dr. Pragyan, and Dr. Divya for their wonderful insights on the topic. Thank you very much. That's it for now, and hope to see you all again in the next sessions whenever we have. Thank you very much for now. Thank you very much.
Thank you, Akhilesh. Thank you, Akhilesh, and thank you, Gunadhar. Thank you.
Thank you, sir. Thank you, Prashant. Thank you.